Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We will have our second presenter, Kylie Wong. She is currently a PGY2 emergency medicine resident at UW Health, and today she is going to be presenting a journal club on Keppra dosing optimization in the neurocritical population. So I'll leave the floor to you, Kylie.
We will be looking at the Neuro-ARC study today, which is augmented renal clearance, and we were going to look at levetiracetam dosing and how to optimize that in our neurocritical care population. So our objectives for today is to assess the prevalence of augmented renal clearance in neurocritical care patients, as well as evaluate dosing regimens for levetiracetam in patients with augmented renal clearance. So some background, augmented renal clearance, or ARC, affects the elimination of renally cleared medications, so it's processing it faster than a normal person would, which potentially causes failures in therapy or insufficient drug levels. Currently, the prevalence in neurocritical care population specifically is about 74%, and those at risk for ARC are those with severe neurological injuries such as traumatic brain injuries, subarachnoid hemorrhages, sepsis, trauma, surgery, burns, or even those of younger age. The definition of ARC is a measured creatinine clearance of greater than or equal to 130 milliliters per minute per 1.73 meters squared. The best way to calculate ARC is through urine collection, a 24-hour urine collection specifically. This article actually used an 8-hour urine collection. It was just less labor intensive, and it seemed to have produced the same efficacy as a 24-hour. However, I know that's not specifically what we're doing in most hospitals. We kind of go off our creatinine clearance that we all calculate with our Cockcroft-Gault equation, and that definition still stands true using that definition. But if you ever wanted to calculate a measured creatinine clearance, you would take your urine creatinine concentration, times that by the total urine volume collected, and you're going to times that by 1.73, and then divide that by your serum creatinine, your urine collection time in minutes, and the patient's body surface area. So a little bit about Keppra specifically. It is an anti-seizure medication, or an ASM, that treats focal or generalized seizures, also seen for seizure prophylaxis or status epilepticus. Conditions that you typically would see it used in is, again, your traumatic brain injuries, your subarachnoid hemorrhages, intracerebral hemorrhages, or status epilepticus. I put a star next to subarachnoid hemorrhage because depending on your institution, you might not be routinely using it as prophylaxis anymore, as the recent 2024 updated guidelines for neurocritical care and AHA and ASA subarachnoid guidelines actually updated that you should not, and they no longer recommend it for routine use unless they are very, very high risk. However, us at UW here, we still use it as prophylaxis. Another thing I wanted to mention is that levetiracetam is not monitored by levels like other anti-seizure medications are. Things that I think about are like phenytoin or valproic acid. It's typically dosed based on efficacy, so if they're taking it and their seizures are not occurring, then that seems to be adequate enough versus getting a level and seeing if that level is in therapeutic range. So actually most people sit below therapeutic range even without experiencing seizures. Some pharmacokinetics about levetiracetam. It is 100% bioavailable and it's rapidly absorbed. Its volume of distribution actually replicates water, so it's at that 0.5 to 0.7 liters per kilo. This is not a medication I would typically think for protein binding, which stands true. It is less than 10% protein bound. Its half-life actually for both IR and ER is about 6 to 8 hours, so it's the same. The ER, just for the outpatient world, typically has less side effects, so like those mood swings. Excretion is through the urine at about 66%. However, 27% of that is inactive metabolite that gets inactivated through glomerular filtration. And then the clearance, if you ever wanted to calculate it, is 0.96 milliliters per kilo per minute. So methods of this article that we're reviewing. So the trial design was a multi-center prospective observational study that consisted of 50 patients. They consented patients anywhere between the timelines of January 2022 to September 2024. The objective of the study was to characterize levetiracetam pharmacokinetics in neurocritical care patients, identify covariates significantly influencing drug clearance, and provide clinicians with optimal dosage recommendations in those with and without ARC. And then the dosing that they typically saw in patients that they were looking at was 500 to 1500 milligrams twice daily, with the most common regimen being 1000 milligrams twice daily, which is what we typically see. And then just to make note that 32 of those patients were receiving IV, while 18 of those patients were receiving oral. They also used simulations, so the PK Analytics 2024 R1. This helped them do a population PK as well as the Monte Carlo simulation, which we'll talk a little bit about later, as it helped us with their dosing simulations. And they did a sample point of 4 collections for the levetiracetam levels. They did a trough, a 1 hour, 4 hour, and 6 hour after the dose was given to help that dosing simulation with giving them points to see and populate more different situations than just the 50 patients that we had. So some inclusion and exclusion criteria of this article: you had to be 18 years or older, diagnosed with a subarachnoid hemorrhage, traumatic brain injury, intracerebral hemorrhage, status epilepticus, ischemic stroke, or meningitis. You also had to have a Foley catheter at time of consent and receiving either prophylactic or treatment doses of levetiracetam. And it didn't matter which formulation. And then exclusion criteria is your typical pregnant women, incarcerated individuals, and those undergoing dialysis, as that would skew the study, and if they were projected to have a less than 72-hour ICU stay, because they wouldn't be able to collect all the data points they needed. Some demographics of the study. This is a lot to look at, but we're going to look at specifically the ones that are kind of important. So the number of patients in each group, ARC group had 35 versus the non-ARC group had 15, so that's a 20 patient difference. Between both groups, there was more prevalent male sex, so 25 in the ARC group and 10 in the non-ARC group. Your serum creatinine between the two were statistically significantly different at 0.59 and 0.83. And I highlighted TBI specifically because that was the most prevalent diagnosis between the two groups. Between measured creatinine clearance and estimated creatinine clearance, it was more prevalent that the ARC group had a higher creatinine clearance versus the non-ARC group. And these are averages. For our non-compartmental analysis, so this is what we used our PK Analytics to help get a population PK. Things that they looked at was dose normalized AUC 0 minus tau, so drug exposure per unit dose, dose normalized Cmax, and dose normalized Cmin, so those are helping with our linear kinetics, apparent systemic clearance, elimination half-life, and our volume distribution of the medication. For our dosing simulation, they used the Monte Carlo simulation, and they looked at total daily doses anywhere between 500 to 6,000 milligrams, while also using dosing intervals of 6 hours, 8 hours, and 12 hours, which is typical levetiracetam dosing that you may see. And then for optimal probability of target attainment, or PTA, that was set at 80% or greater, and that was used to help determine the percentage of patient population likely to achieve the specific drug exposure target, so kind of targeting efficacy of that medication. With that, you might be wondering what that target range was. So it is 12 to 6 milligrams per liter, and that is just noted from the International League Against Epilepsy. That's the reference range they use. One thing I would note is that this is pulled from an abstract, and it's kind of unclear whether this is a mean concentration versus a trough concentration, as it kind of alluded to that this was more of a mean concentration, while other studies that cited this abstract kind of took it as a trough concentration. So this study also helps determine whether this is a good concentration to target. So for results, there were 8 patients out of the 50 patients that had a seizure occurrence after being on maintenance dosing. One of those patients had no ARC and was receiving prophylactic dosing, so that 500 milligrams twice a day that you typically see, while 7 of those patients did have ARC and was receiving treatment dosing. So that kind of begs the question of what they're trying to answer in this study, of whether ARC affects that levetiracetam clearance. Of those 8 patients, 3 patients needed an increase in dosing, 4 patients needed co-administration of either phenytoin, diazepines as needed, propofol or midazolam, along with their levetiracetam, and 5 patients were already receiving that concomitant dosing, anti-seizure medications, so things like lacosamide, valproic acid, and phenytoin. So for our non-compartmental analysis, I just brought up these slides again to reiterate what we were looking at, but we'll go through them individually. So for our dose-normalized AUC 0 minus tau, that is still looking at drug exposure per unit dose. That actually got significantly reduced. And then we're also looking at dose-normalized Cmax, what kind of helps us with our linear kinetics. So if it shows a decrease, that may indicate satchel absorption or increased metabolism, which actually did get showed that it significantly got reduced, as well as our dose-normalized Cmin. It also got significantly reduced. Our apparent systemic clearance had a higher total body clearance. So patients that they were looking at actually were clearing levetiracetam quicker than what you would expect. Our elimination half-life, we had a significant shorter elimination half-life, which makes sense because our higher total body clearance was quicker. And then our volume of distribution actually showed no statistical difference, which is not surprising because this is not a highly protein-bound medication or metabolized by CYP enzyme, so none of these should be affected, and that's not true. For our dosing simulation, just to reiterate, our reference range was 12 to 46 milligrams per deciliter, and what they found was that 500 milligrams twice a day was actually suboptimal for all measured creatinine clearances. So these are the recommended doses that they actually projected after doing the simulation with the Monte Carlo simulation. So anyone with a creatinine clearance of 60 to 89, you would use a dose of 1,250 milligrams twice a day, and that would allow you to be in that reference range or higher. If you were between 90 to 129, a dose of 1,500 milligrams twice a day was needed. And then this is where you start to see your ARC patients of 130 milliliters per minute per 1.73 meters squared or greater. They actually found that a minimum of 1,500 milligrams twice a day was needed to hit that reference range. And then for those with even more significant augmented renal clearance of greater than 200 or more, you should initially start at that 2,000 milligrams Q12 and then see if we have any seizure activity after that. This is a better picture or image of what it looks like. So this is straight from the study, and it looked at all the different creatinine clearance ranges. As you can see, if you just look at the 500 Q12, like you're already starting at that bottom range in the 60 to 89, which is about what in quotes is a normal creatinine. And then you can see that it decreases from there and you're lower than that range. And then you go to 500 Q8 and you're pretty much in the therapeutic range up until maybe we hit that augmented renal clearance. I also like this table because it shows that they did look at the Q12, Q8, and Q6 frequencies, and what they found was that it didn't matter what frequency you used. Q12 is just optimal for everyone, especially for nurses, like you're doing it less times a day, and then they probably will be transitioned to some oral medications, outpatients for some time, depending on your neurologist, and that's just better adherence for patients in the long term. But if you look at 500 Q8, you're in that range, but that would be pretty much similar dosing as 750 Q12, and so you have optimal dosing as twice a day versus 3 times a day or 4 times a day. So for discussions and conclusions, some advantages and limitations to this. So advantages were 50 patients of the population. I think that is a pretty high amount of patients. While it seems low, high for this particular group, to their knowledge, actually it's the biggest cohort reporting PK modeling done in levetiracetam. And also to my knowledge, this is one of the bigger populated studies in the neurocritical care in general. Applicability to all types of kidney functions, as you can see from the previous slide, that they kind of accounted for all types of creatinine clearance. What they didn't do is maybe the lower end, but that's not really what they were looking at. So understandably is not what they charted on. Limitations to the study, it was an observational study design, so they weren't able to make any interventions for anything that they were seeing. They weren't able to intervene on anything. Potentially not generalizable. By that I mean like they had a high prevalence in traumatic brain injuries. So are they able to replicate that in other brain injuries? So like subarachnoid hemorrhage, I know they had a few, but it wasn't a whole lot. There was maybe 6 patients. And then it was a high prevalence of male sex. As us as pharmacists know, women and male have different body types and how we do our different kinetics. So are we able to generalize this to women as well, as we had a very, very high male sex population? And then the limited number of sample points per patient. If you remember me saying they did collect four, they collected a trough, a 1 hour, 4 hour, and 6 hour post dose. If they collected a little bit more, they probably would be able to simulate a little bit more scenarios in their simulation and account for more varieties or verities that could come with that, but they only collected the 4 because of the time constraint that they had and what they were looking for. So overall key takeaways from this article and some takeaways from myself is the prevalence of ARC in this study was 74%, which actually stands true to what other articles have posted of that 74%. ARC significantly reduced levetiracetam concentrations and overall drug exposure. So our patients in ARC were actually clearing that levetiracetam faster and maybe not getting adequate dosing to help reduce those seizure thresholds. In patients with ARC, initial starting doses of 1,500 milligrams Q12 for levetiracetam should be considered because we want to put them at higher so that they're clearing it faster, maybe they still have that adequate amount of coverage. And then the International League Against Epilepsy uses a reference range for levetiracetam of 12 to 46 milligrams per liter. That stands true internationally, but I did want to make a comment that some institutions actually go as low as 6. But based off of this study, I feel like 12 to 46 is a good range, and maybe that's a good study to start and consider maybe we need to adjust this range to higher based off of the simulations that they did. With that, that is the end of my presentations. I will take any questions that you guys have.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.